Hi, this is Eric Michael Lloyd. I'm a master's in psychology, neuropsychology concentration. Today I wanted to read an article regarding brain aneurysms. You might think of that song from the band the rock band Nirvana. But I wanted to read an article regarding brain aneurysms that I'm going to pull up right now. This one is from AHA Journals, Journal of the American Heart Association. This article was written by Mario Zanotti, Lahil Dow, Nora Chalohi, Robert M. Stark, Pascal Jabbour, and David Hassan. This article was originally published the 10th of August 2016. Introduction, and this is the Journal of American Heart Association, JAHA. I have said that already. Introduction. The management of unruptured intracranial aneurysms, UAs, has been a very controversial topic in neurosurgery. There is no clear consensus at present as to when a small UA should be treated and when it should be observed. The magnitude of this problem is increasing with advances in imaging, its widespread use, and the introduction of family screening, which have led to an increased rate of identification of small UAs. The prevalence of cerebral aneurysms, CAs, in the general population is thought to be somewhere between 1% and 7%. However, aneurysmal subarachnoid hemorrhage, SAH, remains a rare event with incidence of 6 to 20 cases per 100,000 persons per year. This highlights the importance of patient selection for treatment. The estimated 1% annual risk of rupture, even though small, has a tremendous impact on the patient's health, given its high mortality and morbidity rate. This estimated risk, however, is not absolute, as it may be decreased from 0.1% to 0.7%, depending on certain characteristics. The best evidence we have thus far comes from the ISUIA, International Study of Unruptured Intracranial Aneurysms trial, which stratified the risk of rupture according to aneurysm size. This study reported a 5-year ruptured rate of 0% for aneurysms smaller than 7 millimeters in the anterior circulation and 2.5% for those smaller than 7 millimeters in the posterior circulation. The standard of care has been to observe these lesions, especially in the absence of high risk factors, based on patient history or aneurysm characteristics and geometry. A 2002 study evaluating the natural history of unruptured cerebral aneurysm in a Japanese cohort showed that larger size, posterior circulation aneurysm, and presence of a daughter sac confers a high risk of rupture. In contrast to these findings, the ISUIA, several studies have reported results showing that the majority of SAHs result from aneurysms less than 10 millimeters in size, and a significant proportion of patients present with ruptured aneurysms less than 5 millimeters in diameter. Korja et al. Evaluated the lifelong rupture of intracranial aneurysms in a Finnish cohort and concluded that treatment decisions of UIAs should be based on the risk factor status, since even small UIAs still rupture. It is still unknown whether it is safe to observe patients harboring small aneurysms, especially if they are planning on engaging in strenuous activities or planning on getting pregnant, or there are any anticipated future events that may carry significant hemodynamic changes, diving, athletic sports, etc. It is also not well established whether it is sufficient to advise treatment in this subpopulation based on hypertension, smoking, or some geometric characteristics such as aspect ratio, defined by height, neck width, non-sphericity index, and size ratio. On the basis of hemodynamic factors and inflammatory changes, we review the evidence that goes against the traditional dogma. A subset of aneurysms smaller than 5 to 7 millimeters are at high risk of rupture and warrant treatment. The predictors of elevated risk of rupture can be categorized into two main variables: inflammatory index and hemodynamic instability. Inflammation and rupture. It is becoming clear that inflammation is a major player in pathophysiology of CAs. This has been well studied in humans and animals. The previous model of aneurysms that assumes a static passive dilation of tissue is being abandoned for a more comprehensive model focusing on inflammation, hemodynamic factors, tissue degeneration, and genetic and environmental factors. The currently adopted model presumes that an inflammatory process is initiated by a hemodynamic insult that leads to matrix metalloproteinase mediated degradation of the extracellular matrix and apoptosis of smooth muscle cells, which are the predominant matrix synthesizing cells of the vascular wall. These processes act in concert to weaken the arterial wall progressively, resulting in dilation, aneurysm formation, and ultimately rupture. Although several constituents of the inflammatory response may be involved, recent data indicate that macrophages play the central role in the process of aneurysm formation and rupture through the secretion of cytokines and metalloproteinases responsible for inflammation and digestion of the arterial wall. Macrophages are present early in ruptured aneurysms and have been linked to rupture. Effectively, inhibition of metalloproteinase has been shown to decrease the incidence of advanced aneurysms in animal studies. It is postulated, based on human studies, that a predominance of macrophage subtype M1 over M2 and upregulation of mastocytes may increase the risk of rupture. Given the critical role of macrophages in the pathophysiology of CA rupture, several studies were conducted to investigate the inflammatory status of human CAs through direct macrophage imaging. Along these lines, Hassan et al. Have investigated the feasibility of optimal parameters for imaging macrophages in human CAs using furomoxetol enhanced magnetic resonance imaging. Furomoxetol, a member of the class of nanoparticles known as ultrasmall superparamagnetic iron oxide, is a useful intravascular contrast agent and an inflammatory marker when imaging is delayed because it is cleared by macrophages, usually within 24 to 72 hours. In their initial work, Hassan et al. Found that the optimal technique for imaging macrophages in human CA walls is infusion of 5 milligrams per kilogram of furomoxetol and imaging at 72 hours after injection. Aneurysm tissue harvested from patients infused with furomoxetol sustained positive infused with furomoxetol stained positive for CD68, marker of macrophage lineage, demonstrating macrophage infiltration, and stained positive for Prussian blue, demonstrating uptake of iron particles. Tissue harvested from controls, i.e. patients who underwent clippings but were not previously infused with furomoxetol, stained positive for CD68 but not Prussian blue. This study helped to establish that infusion dosing of 5 milligrams per kilogram of furomoxetol and imaging at 72 hours post-injection using T2 GE-MRI constitute the optimal dose and timing parameters for imaging of macrophages within the aneurysm wall. However, some aneurysms showed early uptake at 72 hours, well before the others. The significance of early uptake, however, was not clear at the time, but the authors thought it might be associated with a more active inflammation and thus linked to a higher risk of rupture. Hence, a subsequent study was conducted to verify this hypothesis, where 25 aneurysms were imaged to compare early 24 hours versus late 72 hours or no uptake. 7 of the 25 aneurysms demonstrated by early uptake. Of these 7 aneurysms, 4 were clipped and 3 were observed. All 3 observed aneurysms progressed to rupture, including a above or greater than 7 millimeter aneurysm. On the other hand, 18 of the 25 aneurysms did not show early uptake. Of these, 9 were clipped and 9 were observed. None of the observed progressed to rupture, including a giant aneurysm. The authors elected not to treat the aneurysm due to the patient's age and morbidity. In conclusion, all aneurysms with early uptake ruptured, and those with no or late uptake did not rupture or change in size morphology, despite a follow-up period of 2 years, as of the current time. Furthermore, the authors found that CAs with early uptake had increased M1 cells and exhibited a more intense inflammation in their walls, similar in magnitude to ruptured aneurysms, harvested tissue from control patients, and significantly higher than patients with late uptake. P-value less than less than 0.05. Interesting, so 95% confidence interval. Interestingly, early MRI signal change was independent of aneurysm size. Late MRI signal change was noted in 50% of aneurysms lesser than 7 millimeters and 44% in aneurysms 7 to 14 millimeters. To sum up, there were no subarachnoid hemorrhages in 9 patients without uptake compared to all 3 patients with uptake. We performed a Fisher exact test and found this difference to be statistically significant. Fisher exact is equal to 0.0045. Aneurysms with early uptake of furomoxetol on MRI may be prone to rupture and thus may warrant early operative intervention, regardless of size. That's all that I'll read for right now. I'm going to read the next part, going over Figure 1, the download PowerPoint, and also the next section, which is hemodynamic factors predisposing to rupture, and throughout the rest of the article in the next video. Thank you for your time.